Welcome to the deep dive. Today we're diving into something pretty specialized, pediatric vascular surgery.
Right.
You hear a lot about pediatric cardiac surgery, but vascular issues in kids, it seems, well, less charted territory.
That's a good way to put it. And part of the reason is the sheer variety of conditions.
Yeah.
And the number of different specialists involved.
Yeah, the list is long: pediatric surgeons, adult vascular surgeons, cardiothoracic, transplant, urology, plastics, even general surgeons. It's quite the team.
Absolutely. It can feel a bit like a maze. So our mission here really is to pull out the core ideas, the key techniques you need to understand when treating vascular problems in children. We're leaning heavily on a key textbook chapter for this.
Okay, great. A focused look. So where do we start? Maybe looking back a bit. This isn't all brand new, is it? There's history here.
Oh, definitely. You can find observations about congenital vascular issues way back in the 16th century. Guidi mentioned them.
Wow, 16th century.
Yeah. And then Morgagni in 1760, he gave the first really detailed description of aortic coarctation, that narrowing of the aorta.
So these early guys were really laying the groundwork.
They absolutely were, just by describing what they saw. And then later, Meckel added more details about coarctation, like the collateral blood vessels that form and how it can erode the ribs. Schlesinger, around 1835, he pointed out that coarctation wasn't always in the same spot. And Potain was the one who linked it to high blood pressure.
Connecting the dots.
Exactly. And Schlesinger and another physician, Quain, also saw rarer types of aortic narrowing lower down. It really shows how important just careful observation has always been.
It's a neat progression from just seeing it to understanding the effects. What about things like high blood pressure caused by kidney artery problems in kids, renovascular hypertension?
Right, that's another key historical thread. Ledbetter and Birkeland, back in 1938, were the first to really recognize that in a child.
And what do they find?
Well, crucially, they saw that removing the affected kidney actually cured the hypertension.
Just like that.
Pretty much. That was a big deal, showing that direct link between the renal artery problem and the high blood pressure, and that surgery, even removing the kidney, could fix it.
Okay, so some early successes. But the chapter mentions that for a while, operating on tiny infant blood vessels was seen as, well, really dangerous.
It was, and understandably so. The real game changer, or at least a major turning point, was Starzl's successful pediatric liver transplant in 1967.
A liver transplant? How did that impact vascular surgery?
Well, think about it. A liver transplant involves connecting multiple blood vessels. Really delicate work. Starzl did this successfully in a young child with a large tumor, proving complex vascular surgery was possible, even in very young patients.
Ah, I see. It broke down a barrier.
Precisely. And then people like Dean, Stanley, and Fry made huge strides, specifically in treating pediatric renovascular hypertension. So over the last, say, 30 or 40 years, we've built up this massive amount of experience, both clinical and technical. Outcomes are much more consistent now.
Right. It wasn't one single event, but this gradual accumulation of knowledge and skill.
Exactly.
Now, there's a core principle mentioned attributed to Ladd and Gross, kind of foundational figures in pediatric surgery.
Yeah, absolutely. Their 1941 textbook is a classic. Their big emphasis was on gentle tissue handling.
Sounds basic, but crucial, I imagine.
It's fundamental. You have to minimize trauma.
Ah.
And while, sure, there are similarities to adult vascular surgery, the chapter stresses the key differences. Things like fluid management, anesthesia, and the big one, always considering the child's future growth.
Growth. Yeah, that makes total sense. It's not just a small adult system.
Not at all. It's dynamic, constantly changing.
Which leads us right into the main discussion. Let's start with timing. When do you actually do the surgery? What guides that decision?
Okay, so the general rule, if the clinical situation allows, is to wait. Delay major vascular reconstructions in really small infants, especially if the vessels are tiny, like less than 2 millimeters.
Why wait?
It boils down to technical difficulty and, frankly, better long-term results if you can wait. Those tiny vessels are just incredibly challenging to work with.
Okay. Any specific examples where delaying is common?
Yeah, renovascular hypertension is a good one.
Yeah.
The trend is often to put off fixing the renal artery until the child's at least 3 years old.
3 years? Why them?
The success rates seem to be better, more durable if you wait until they're a bit bigger. And interestingly, really severe hypertension in newborns right after birth is actually pretty uncommon, maybe 0.2 to 2%.
So you can manage them with medication for a while?
Often, yes. And using antihypertensive drugs for a prolonged period to allow the child to grow hasn't really shown significant long-term harm.
So wait if you can. let them grow, make the surgery technically easier, maybe more lasting. But I assume there are times you just can't wait.
Absolutely. If an infant has severe uncontrolled hypertension that's causing major problems like heart failure or shock, then you have to intervene earlier, no matter the age.
Right, life-saving measures trump the general rule.
Exactly. There was a case mentioned from the University of Michigan, a 3-month-old with both renal arteries blocked. They intervened successfully. It highlights that balance delay is ideal, but sometimes early surgery is essential.
It's always that risk-benefit calculation for the individual patient. Okay,
Yeah.
what about something like thoracic coarctation, that narrowing in the chest aorta? Is the timing different there?
Yes, generally it is. For thoracic coarctation, early repair is usually recommended.
Why the difference?
The risks of the surgery itself are quite low, perioperative mortality is low, and the chances of needing another intervention later aren't that high either. But more importantly, fixing it early helps prevent long-term problems like persistent high blood pressure and vascular dysfunction that can develop if you leave it untreated.
So with coarctation, the long-term consequences of not operating early weigh more heavily.
That's a good way to think about it, yes.
Okay, let's shift gears. Anticoagulants and antiplatelet drugs, blood thinners. I imagine managing this in kids has its own set of challenges.
Oh, definitely. It's a whole different ballgame. A child's coagulation system, how their blood clots, is constantly maturing. Plus, how they handle drugs, the metabolism, changes with age.
And practical things too.
Yeah, practical hurdles too. Getting reliable IV access for monitoring can be tough. Not all medications come in easy-to-give liquid forms. Diet can interfere, especially with older drugs like warfarin. And just getting kids to take medicine consistently can be a challenge.
Right. Let's talk specifics. Heparin, that's been around a long time. How is it used in kids?
Heparin is still a workhorse, very safe record. It's given routinely during surgery, usually as a bolus based on weight, when you need to temporarily stop blood flow.
But monitoring it might be different.
That's the key point. The standard blood test, the APTT, its therapeutic range, is based on adult blood. Young kids often have a naturally higher baseline APT.
So the test might look like the heparin is working better than it actually is.
It can overestimate the effect, especially newborns. Maybe only 70% accurate in predicting the actual drug level. And the maintenance dose needed, the continuous infusion rate, also changes with age. Infants typically need a higher hourly dose than older kids.
Interesting. And reversing heparin. Protamine sulfate is the usual antidote in adults, same in kids.
It can be used, yes. But often in newborns and very young infants, surgeons might avoid it.
Why avoid it?
Because these little ones clear heparin out of their system pretty quickly anyway. The thinking is, letting it wear off naturally might actually help prevent clots forming in those very small vessels right after surgery.
Huh. Sometimes doing less is more. What about longer-term anticoagulation after the surgery? You mentioned warfarin challenges. What's used instead?
Yeah, there's been a definite shift. Low molecular weight heparin, or LMWH, is generally preferred now.
Why LMWH?
Several reasons. Warfarin, or vitamin K antagonists, are tricky in newborns. They naturally have low levels of vitamin K-dependent clotting factors. Plus, warfarin usually comes as pills, hard to dose precisely, and breast milk is low in vitamin K.
Okay.
LMWH needs less frequent blood test monitoring, has fewer drug interactions, and a lower risk of a specific complication called heparin-induced thrombocytopenia.
So LMWH is better, but still has challenges.
Dosing can still be variable in kids, and it requires injections under the skin. That's why there's ongoing research into the newer oral anticoagulants, the NOACs, for children. But we don't have a ton of data on them yet.
Okay, so LMWH is the current standard, but things are still evolving. What about antiplatelet drugs, things like aspirin?
Yeah, antiplatelets have been used for decades. Aspirin, often in very low doses, is frequently used, especially after fixing really small vessels, sometimes given right during surgery via a feeding tube.
Is there a risk with aspirin in kids? Like Rey syndrome?
At these low doses, the risk of Rey syndrome is considered extremely rare. And more recently, another drug, clopidogrel, is being used more, particularly in kids who also have heart disease. Studies show it works well at the right dose, even in young children. Got it. Okay, moving to another critical piece. Pediatric anesthesia and perioperative care. This must require incredible expertise.
Absolutely. It's a highly specialized field. Huge progress has been made since the first dedicated textbook by M. Digby Lee back in 1947.
What are some of the core principles?
Well, keeping the child warm, maintaining normothermia is paramount, especially in babies. Operating rooms are kept warmer, inhaled gases are warmed and humidified, 5E fluids are warmed, warming blankets are used. It's meticulous.
And equipment.
You need a full range of correctly sized equipment. Masks, breathing tubes, everything has to be tailored to the child's size.
And the airway must be a huge focus.
The airway is the critical thing. You need deep knowledge of how a child's airway develops and functions. Post-op airway problems, laryngospasm, low oxygen, croup, aspiration. Sadly, they account for a significant chunk of complications.
How is putting a child to sleep for surgery different? Often, anesthesia is started by having the child breathe anesthetic gases, like sevoflurane, rather than starting with an IV like in adults. And after surgery, placing the child in the recovery position, on their side, is standard practice. It helps keep the airway open and manage any vomiting.
Is vomiting more common in kids after surgery?
It tends to be, yes. So anti-nausea medications are often given preventatively, sometimes dexamethasone too, which can help with both nausea and any swelling in the airway. It's all about anticipating and preventing problems.
It sounds like incredibly careful, detailed work. So let's get into the actual vascular techniques. The chapter says choosing the right procedure is most important, but the how matters too, right?
Of course. Technique is vital. Proper positioning, getting good exposure, good lighting, the right incision, clamp selection, sutures, conduit choice if needed, making the connections, the anatomy, it all has to be done correctly. But yes, starting with the right plan is step one.
What about the tools? Just mini versions of adult instruments.
Mostly, yes. Smaller forceps, clamps, needle holders, scissors. There are specific examples like Baby Jacobson or Potts Bulldog clamps. They have a very gentle grip for delicate vessels. And Yessergill or Heifetz clips for really tiny, fragile ones.
Forceps.
Delicate forceps like DeBakey and fine Geralds are used to handle tissues gently. And specific scissors, Metzenbaum, Stevens tenotomy, Potts Dietrich, allow for very precise cutting.
And retractors to hold things open.
Yep, both self-retaining ones and handheld ones, just like in adults, but smaller. For biliary surgery, the Thompson pediatric system is popular. It has low-profile blades that work well in a small space. For arms, legs, neck, white lantern retractors of various sizes are common.
Okay. When you're actually getting to the vessel and needing to control it, exposure and clamping, what are the key things to keep in mind for kids?
The goal is always the most direct route with minimal disturbance to surrounding tissues. We prep a wide area just in case the incision needs to be extended. Landmarks are crucial, and often a handheld Doppler probe is used to find the vessel if you can't feel a pulse. Interestingly, in young kids with their sort of barrel-shaped chests and bellies, a transverse, or sideways, abdominal incision often gives better exposure than an up and down one, and it might even have a lower risk of the wound opening up later in babies under 1 year.
And clamping the vessel.
Gentle handling is everything, preventing tears or bleeding. And side-biting clamps, which partially clamp a vessel, are generally avoided. The vessels are just too small, and there's a real risk of accidentally catching the back wall with a suture, which could cause a clot.
That emphasis on gentleness again. Once you've made a cut in the artery, an arteriotomy, how do you close it?
The simplest way is primary closure, just sewing the edges together. But the worry in a growing child is that this might create a narrowing, a stenosis, as the vessel grows.
So you need to account for growth.
Exactly. So surgeons have to judge, will primary closure be okay, or do we need a patch? Similar thinking to adults, but with that growth factor added in.
A patch, like a piece of material sewn over the opening.
Precisely. And some surgeons prefer using interrupted stitches, individual knots, for patch repairs in kids instead of a running stitch like in adults.
Why interrupted?
The idea is it might allow the vessel to expand more naturally as the child grows. And the patch itself has to be big enough, obviously, not to restrict future growth. Patch repair is actually quite common in pediatric trauma involving blood vessels.
Okay, patching for growth.
Yeah.
What if you need to replace a whole segment of artery or create a bypass around a blockage? When does that happen in kids?
It's usually for things like aneurysms weakened, ballooning arteries, or blockages. These aren't as common as in adults, but you see them with certain connective tissue disorders, tuberous sclerosis, sometimes infections, inflammatory conditions like mid-aortic syndrome or after trauma.
And how do you fix it? Bypass.
Bypass grafting is common. But sometimes, if it's a short segment, you can cut out the bad part and either reimplant the vessel slightly differently or just sew the healthy ends back together and end-to-end anastomosis. Reimplantation is often used for peripheral aneurysms or for renovascular hypertension, especially if the blockage is right where the renal artery comes off the aorta.
You mentioned a specific technique for reimplanting the renal artery.
Yes, the end of the renal artery is usually spatulated.
Spatulated.
Meaning it's cut on an angle, creating a wider oval opening. This gives a bigger surface area for sewing it back onto the aorta. usually under the aorta, sometimes the iliac artery in specific situations like kidney transplant.
Okay.
And they often use an aortic punch, a tool to create a perfectly sized oval hole in the aorta for the reimplanted renal artery. You actually want to oversize it slightly to prevent narrowing later.
And sutures again. Interrupted.
Often preferred, yes, unless it's an older adolescent with adult-sized vessels.
Ah.
And sometimes you need to free up the kidney a bit so the connection isn't under tension.
And what about aneurysms elsewhere, like in the arms or legs?
For peripheral or visceral aneurysms, renal, splenic, brachial, femoral, popliteal arteries resection, and primary end-to-end anastomosis is often feasible. Cut out the aneurysm, sew the healthy ends back together. Again, spatulating the ends helps prevent narrowing.
Bypass grafting sounds more complex, an extra connection, choosing the graft material. What are the main reasons for bypasses in kids?
In the arms and legs, usually peripheral aneurysms or trauma could be from an accident or even damage during another procedure. For the aorta, the big ones are abdominal aortic coarctation, that mid-aortic syndrome we mentioned, and renovascular hypertension caused by renal artery stenosis.
Mid-aortic syndrome sounds challenging.
It really is. Typically presents in the first or second decade with a really tough-to-control hypertension. The narrowing is usually high up in the abdominal aorta and often involves the arteries to the kidneys or intestines too.
How is it treated?
The largest series, by Stanley and colleagues, mostly use bypass grafts, either a thoracoabdominal bypass starting higher up in the chest or an aorto-aortic graft just within the abdomen. Many needed kidney or intestinal artery bypasses at the same time.
What kind of graft material did they use?
Mostly expanded PTFE, a synthetic material. They felt it was less likely to stretch out over time compared to Dacron.
And sizing must be absolutely critical, right, for growth?
Hugely critical. You have to oversize the graft compared to the child's current aorta so it doesn't become too small as they grow. The chapter gives guidelines for different ages. Interestingly, graft length isn't as big an issue after age 10 or so because the aorta doesn't grow much longer after that.
Do these grafts last?
Patency seems excellent long-term, like 97% at 5 years in that series. But these kids need lifelong follow-up. You have to watch for the graft being outgrown, narrowing at the connections, or problems with any associated visceral artery repairs.
So prosthetic grafts work for the big aorta reconstructions. What about smaller vessels like kidney or leg arteries? Is vein preferred there?
Traditionally, yes. The patient's own great saphenous vein, the GSV from the leg, has been the go-to.
Any downsides to using vein?
Yes. Especially in young kids, unsupported vein grafts can sometimes dilate or even form aneurysms years later. It seems less of a problem for leg bypasses, but for aortorenal bypasses, it's a known concern.
So what do surgeons do?
Some will wrap the vein graft, particularly if it's coming off the aorta or iliac artery, with Dacron mesh for extra support. Another good option, maybe even more durable long-term than vein in some cases, is using the internal iliac artery as the graft.
Okay. The chapter also mentioned something really novel for mid-aortic syndrome tissue expansion, avoiding a graft altogether.
Yeah, that's a really fascinating technique. They place a tissue expander, like a small balloon, behind the narrowed part of the aorta.
And inflate it.
Gradually over time. This stimulates the aorta and iliac arteries to actually grow longer. Eventually, there's enough length to cut out the narrow section and sew the healthy ends together directly. No graft needed.
Wow, using the body's own growth potential. That's clever.
It really is a very innovative approach.
Okay, let's switch to endovascular techniques. Minimally invasive stuff. Huge in adults. How's it translating to kids?
It's definitely growing, mirroring the adult world. We can do increasingly complex things through catheters now, but there are key differences.
Like what?
Contrast dye volume is critical, much lower limits based on weight. Hand injection is often preferred for smaller kids, under 15 kilos, for better control. Heparin is usually given routinely after getting arterial access in those smaller kids to prevent clots in the access artery, usually the femoral.
Getting access must be trickier too.
Ultrasound guidance is standard, using tiny needles and wires, then placing small sheaths, maybe 3 to 5 French. There are some pediatric-length catheters, but we lack dedicated devices for closing the artery puncture site in kids.
Are complications more common?
Access site complications, hematoma, dissection, clots, pseudoaneurysms, AV fistulas are generally uncommon, but they happen more often in babies under 1 year, maybe up to 10%.
What's the biggest worry with access?
Vessel thrombosis, a clot forming, especially due to spasm in those small arteries in kids under 15 kilos. Rates up to 16% have been reported. That's why prophylactic nitroglycerin is sometimes given directly into the artery.
Okay. When treating blockages, are stents used as much as in adults?
Generally, no. Balloon angioplasty is often preferred over stents.
Why is that?
Well, the equipment for angioplasty, the balloons, can fit through smaller sheaths, which is better for small vessels. But the main reason is growth. Stents are rigid metal scaffolds. They don't grow.
Ah, so the vessel grows, but the stent doesn't.
Exactly, which means the child often needs repeat procedures, more angioplasty, to stretch the stented area as they grow. Sometimes the stent even needs to be surgically removed later in life.
How well does balloon angioplasty work on its own? For example, for renovascular hypertension.
Results have been a bit mixed. One series showed only about 54% blood pressure control long-term, and over a third had restenosis. The narrowing came back. So stents are usually reserved for bailout situations in renal arteries, like if the vessel wall tears or recoils badly right after angioplasty.
What about other areas? Liver transplants.
Hepatic artery stenosis can happen after liver transplants in kids, maybe up to 20%. Percutaneous angioplasty seems to work quite well there, using small balloons, but again, long-term data is still limited.
And aortic coarctation. Angioplasty versus surgery.
Balloon angioplasty for coarctation has been done safely since the 80s, but durability is the question. Some long-term studies show a significant rate of recoarctation needing reintervention, maybe 25%, and even some aneurysm formation at the angioplasty site years later.
So endovascular offers less invasive treatment, but maybe at the cost of long-term durability compared to open surgery.
That seems to be the trade-off, yeah. Similar to what we see in some adult situations, and we have to be careful just applying adult data, which is mostly for atherosclerotic disease, to kids whose problems are often congenital and fundamentally different. Technology will improve, success rates will likely get better, but it's a different landscape.
This has been incredibly insightful, really peeling back the layers on pediatric vascular surgery. If you had to summarize, what are the absolute key differences, the main challenges, compared to operating on adults?
I think it always comes back to growth. You're operating on a dynamic, developing system. That consideration underlies almost every decision. Then there's the unique pediatric coagulation system and just the sheer scale, the small size of the vessels and the patient. Those are the biggest things.
And despite those challenges, it sounds like the field has come a very long way.
Oh, absolutely. From those very early observations centuries ago to the sophisticated open and endovascular techniques we have today, the progress in treating these complex conditions has been immense. It offers real hope for these young patients.
So looking ahead, with technology evolving so fast in both surgery and endovascular treatments, it really makes you wonder, doesn't it? What will the treatment landscape for these kids look like in another decade? How big a role will minimally invasive options play in their long-term care?
That's the big question. It's definitely a field to watch.
A fascinating thought to leave our listeners with. If you want to explore this further, definitely check out the key references in the source material we discussed. Thanks so much for joining us on this deep dive.